Alterations in reproduction, disorders of the male reproductive system. Torsion of the spermatic cord is basically a twisted spermatic cord. It involves the rotation of the testicle that twists the cord around the artery, causing it to kink and compromises blood flow to the testicle. It occurs most often in adolescent boys and those whose spermatic cords are congenitally unsupported. These gentlemen feel a sudden, sharp testicular pain, local swelling, nausea, vomiting, chills, and fever. To diagnose this, basically, it just requires a physical examination. Treatment does require immediate surgery. Again, it's cutting off the blood flow, and if we don't restore that blood flow, we could have some serious compromises. Nurses will provide pain management, may require some scrotal support, and postoperatively, we will need to monitor for drainage. Erectile dysfunction is also known as impotence. This is an inability to achieve an erection sufficient for or long enough for intercourse. It may be related to inefficient neurologic stimulation, to a problem with arterial blood flow, with trapping of venous blood. It may have some physical and psychological origins, such as some medications like antihistamines or antihypertensives. There may be decreased libido due to medications, disease processes, a decrease in the amount of hormones, etc. Diagnostically, we can do the nocturnal penile tumescence and rigidity test. We can also do some vascular ultrasound studies. It may be necessary to change the client's medications to drugs that do not cause impotence. Drug therapy may be necessary to facilitate penile engorgement, such as the PDE5 inhibitors. These are indicated for erectile dysfunction, for BPH, or pulmonary hypertension. It is contraindicated with major cardiovascular disorders or the concurrent use of nitrates. Basically, this medication is a vasodilator, and if it is taken with the vasodilator nitroglycerin, it can create life-threatening hypotension. Adverse effects are hypotension, headache, flushing, dyspepsia, priapism, and visual loss. Main drug is going to be the sildenafil, also known as Viagra. And of course, there are a few others out there. Another medication that may be used is testosterone. It is a hormone replacement therapy and is contraindicated in androgen responsive tumors. Adverse effects include pileosis of the liver. In other words, we have some damage to the liver. Hepatic neoplasms or liver cancers. Cholestatic hepatitis, jaundice, abnormal liver function, fluid retention, weight gain, and clot formation. If you recall, I've told you that any hormone, whether it is male or female hormones, increases the risk for clot formation. They can also all increase the risk for weight gain and fluid retention. It does interact with several medications. And again, the main medication is testosterone. Testosterone can also cause some mood swings and can also assist males or females in bulking up with muscle um, building. So additional treatments may include vascular surgery or penile implants. As nurses, we need to direct the client on how to appropriately take medications, what potential complications are, and how to prevent complications following penile implants. Priapism is defined as a persistent erection without sexual stimulation. This is basically a vascular problem. Um, it's a medical condition. It can also be a side effect of medication, such as your PDE5 inhibitors. These gentlemen will have discomfort. There is interference with arterial blood flow and urinary elimination. And if that erection lasts longer than 6 hours, there can be tissue damage that results in permanent damage. So we treat it with vasoconstrictive medications. We can actually insert a needle into the penis and drain some of that trapped blood. And ultimately, it may require emergency surgery. These gentlemen do require some emotional support. BPH, benign prostatic hyperplasia, is an increased number of cells in the prostate. This results in decreased diameter of the prostatic section of the urethra. In other words, it causes constriction of the urethra because the prostate actually uh, is wrapped all the way around the urethra. Erectile dysfunction is uncommon following a TURP, which is a transurethral resection of the prostate to help decrease the bulk of the prostate or actually removes the prostate. BPH has a gradual onset, and this is a normal finding with aging. In other words, men as they age will have enlargement of the prostate gland. This can cause difficulty with urinating and completely emptying the bladder. It causes nocturia, urgency, and a weak urine stream. These men may also have some incontinence or have difficulty getting the urine stream started. We diagnose this with a digital rectal exam, a cystoscopy, an IVP, or blood chemistry test. The PSA may be slightly elevated. Remember, this is the prostate-specific antigen. We can also diagnose it with a transrectal ultrasound. Remember, if we do a PSA, it has to be done prior to the DRE to prevent an elevation in the PSA level. So we treat it by monitoring DREs. What size is it? Has it grown? Is it becoming more of an issue? We can use drug therapy. There are some alternative therapies available, and we can also do some surgical procedures such as a prostatectomy, where we completely remove the prostate, or the transurethral uh, resection of the prostate, or the TURP. This does not cause erectile dysfunction, but it can cause retrograde ejaculation. And basically, that's where the semen enters the bladder instead of traveling through the urethra. So the male experiences what we call a dry orgasm. It does not affect sexual pleasure, but of course, it can lead to infertility. These clients following a TURP are going to then come out of surgery with a continuous bladder irrigation. And this continuous bladder irrigation is basically an indwelling urinary catheter that has 3 pigtails on the catheter itself. One is for the infusion of large amounts of fluid. The second one is going to be for the drainage of the urine itself. And the third one will be for the ability to attach a syringe to the catheter to hopefully manipulate any potential clots or debris. Basically, the continuous bladder irrigation is going to help flush the bladder out. It's going to help remove the debris from the surgery, remove any potential blood clots, so it is passed out through the urethra. But if debris blocks the urethra, the client may experience a significant discomfort from overfilling of the bladder. And to help take care of that, we attach that syringe. We can irrigate to help remove that blockage, or we can do kind of a push-pull method on the syringe to help break that clot loose. We very definitely need to compare the amount of fluid that we flush the bladder with, what is going in the continuous bladder irrigation, if we flush with any fluid, how much we put in, and compare that to the output. Anything that is over what has been put in will be considered urinary output. Of course, this will be pink to red discoloration fluid. So clients with BPH, we as nurses need to educate the client on how to empty the bladder. They should void often. They should lean forward and bear down. That will put pressure on the bladder itself. We encourage the clients to drink small and frequent amounts. We don't want to discourage fluid intake. We still want them to get their fluid, but we don't want them to overfill the bladder. They should limit alcohol and caffeine. They should limit decongestants. And postoperatively, once again, that bladder irrigation, we have to monitor the amount of output. We should at least have what we put in coming back out, but we should have more, which would be the urinary output, and monitor for blockages. Prostate cancer is a common male cancer, and it's second in cause of cancer deaths following lung cancer in the male population. These clients have increased testosterone. Those that have prostate cancer will have increased testosterone. They may be on a high-fat diet. They may have a family history. It does occur in the periphery of the gland, and then they start experiencing some genitourinary symptoms. Untreated cells will spread by the bloodstream and lymphatics. These gentlemen have frequent urination, nocturia, dysuria, hematuria, hemospermia, erectile dysfunction, and if it metastasizes, they may have back pain or pain down the leg. Again, we are going to diagnose by doing a rectal examination and a PSA, and the PSA would come first. Do a transrectal ultrasound. We can do radiographs, an MRI, a CT, an IVP, and an elevated serum acid phosphatase. We encourage these gentlemen to begin having annual screenings at the age of 50. If they are African American, they need to start at a younger age because they are at a higher risk. And if they have a first degree family history, they should be getting these screenings done earlier. Treatment, depending on the extent of the cancer, it may just be observation and it may be surgery. We can do a suprapubic prostatectomy, excuse me, a radical prostatectomy, a bilateral orchidectomy, radiation, hormone therapy, or a combination of any of these. Do realize that removal of the prostate can have an effect on sexual function postoperatively, and they also may have retrograde ejaculation. Recovery can take up to a year before the gentleman knows exactly how sexual function will be affected. But intercourse is only discouraged for a time period of a month, and anxiety can affect function. These clients may also have radiation, hormone therapy, or a combination. Cryotherapy is a procedure that may be used. Men that have stage 3 or 4 carcinoma may receive anti-androgenic or estrogenic drugs, but there are some feminizing side effects to those medications. And they may also receive immunotherapy. So once again, screening should be done in the average male by age 50 with a PSA followed by the DRE every year. True or false? Prostatic screening should begin for all men at age 60 years. And we know this is false. The age is 50 unless they meet certain criteria. Then it will be younger. Testicular cancer is the most common cancer in males 15 to 35 years of age. It does occur more often in white males, in males that have had cryptorchidism, which is a failure of the testes to descend into the scrotum. It may just be delayed, or it may have to be surgically corrected. Early degeneration of cells and undescended testes or abnormal cellular changes can lead to testicular cancer. It usually involves seminomas or non-seminomas. These gentlemen will have scrotal swelling. They may palpate a hard, non-tender nodule. They may have abdominal pain or general weakness, testicular aching, or a heavy feeling in the scrotum. It's diagnosed through tumor markers, IVP, lymphangiography, CT, or MRI. Treatment will depend on the stage of the disease. We can do an autologous bone marrow transplant or a radical inguinal orchiectomy, which is the removal of the testes, spermatic cord ligation, a radical retroperitoneal lymph node dissection, chemotherapy, and radiation. It's really important to address the topic of sperm banking prior to surgery, as you know, if the testes are removed, both testes, then the client will be unable to produce sperm to impregnate a female. Scrotal support postoperatively might be necessary to help relieve pain, and potentially assist with edema. Very important to manage pain postoperatively and provide postoperative teaching. And now your post-test.